Um, Dr. Davis, can you hear me okay?
Yes, well.
Okay, so I'd just like to welcome you all on behalf of the Christus Santa Rosa Friends Foundation. I'm the former president of Medical Center Hospital and now am joining the Christus Santa Rosa Friends Foundation as their president. And we're fortunate to be joined by Dr. Kenneth Davis, who is the Chief Medical Officer for the Christus Santa Rosa Ministry. And Dr. Davis will start us with a reflection.
Thank you, Dr. Thompson. Okay, the next slide, please, Catherine. As I was thinking about what Ken Davis can do in this time of division in our country, what is the action that I should do? I thought about the St. Francis prayer. So let's center our thoughts in prayer if we can. Lord, make me an instrument of thy peace. Where there is hatred, let me sow love. Where there is injury, pardon. Where there is error, truth. Where there is doubt, faith. Where there is despair, hope. Where there is darkness, light. And where there's sadness, joy. O divine Master, grant that I may not so much seek to be consoled as to console, to be understood as to understand, to be loved as to love. For it is in giving that we receive, it is in pardoning that we're pardoned, and it is in dying to ourselves that we're born in eternal life. Amen.
That's lovely. Thank you, Ken. And if we could go forward to the next slide, please. So this noontime update for you is going to be focused on how the Christus Santa Rosa healthcare system responded to the COVID pandemic. And it's completely fitting and appropriate that we're having this today, as the announcement was made this morning that it appears, and we will pray that this is indeed the case, that a new vaccine is showing very, very promising results. And I know that all of us have prayed for that. But this whole process began back in December of 2019. And that's, in fact, on the last day of last year, the Wuhan Municipal Commission first reported a cluster of cases of pneumonia. And these ultimately were determined to be the novel coronavirus that we've lived for almost the last year. The World Health Organization first publishes this on January the 5th. China publishes the sequence of COVID-19 on January the 12th. And the first case outside of China was reported in Thailand on January the 13th. On January 22nd, the WHO convened an emergency committee to assess if a pandemic was possible. They couldn't reach consensus and they determined to gather more information and reconvene in 10 days. But within about 7 days afterwards, because of the rapid emergence of information, they declared that it was a public health emergency of international concern. And by that day, there were more than 7,800 cases worldwide. That was in less than 17 days. Next slide, please. Go to the next slide, please. If we could advance, there we go. And so in terms of preparedness for San Antonio, on January the 24th, Lackland Air Force Base was identified as one of the very handful of reception sites for repatriation of affected cruise lines. And the RMOC in San Antonio was activated. This is the Emergency Management Center for San Antonio, went to level 3 and a coordinated city response. And the hospital system developed an acceptance rotation. The 4 hospital systems determined that we would rotate. University, Christus, Methodist, and Baptist, and Medical Center Hospital was identified as the receiving hospital for Santa Rosa. A Santa Rosa planning team was activated, including facility process and alerts, resources to oversee, as we probably remember, the PPE, personal protective equipment was extremely important, as well as bed utilization. Next slide. And so dozens of these coronavirus evacuees, this is a picture from the Express News, began in early February 2020. The initial evacuees arrived on February the 7th. Initial plans were to quarantine them at Lackland. And initially, we were told that if they left Lackland Air Force Base, they could not return until 2 separate negative COVID tests were obtained 3 days apart. On San Antonio, hospital systems were approached by STRAC, and this was the rotational schedule. Next slide, please. And so Santa Rosa as an organization responded perhaps the quickest of all the organizations, and working with STRAC officials, the Bandera Freestanding Emergency Center, which is about a couple of miles from Medical Center Hospital, was identified as a location where it was anticipated that the patients from Lackland Air Force Base could be moved. It was rapidly reconfigured to be a full ICU capability under some of the waivers from the state. And shortly afterwards, we created multiple negative pressure rooms, prepared to receive as many as 20 to 40% of the passengers who were expected to develop COVID. Fully staffed with ER nurses, ICU nurses, hospitalists. We even had intensive care capabilities that were placed, as well as extensive telemedicine capabilities. And the picture that you see at the bottom, these openings, as you see here, were the exhaust locations for the HEPA, the high efficiency filtration units that were placed to create these negative pressure rooms for the exhaust. Next slide. And Dr. Davis, if you will now take over the coordinated care response for CHRISTUS.
Thank you, Dr. Thompson. You know what? This is a remarkable response from very, very competitive healthcare systems working together to manage this pandemic emergency. Next slide, please, Catherine. Some things that we did, we coordinated, as Dr. Thompson said, through STRAC, which is the Regional Advisory Council. There are 22 trauma regions in Texas, and this oversees our trauma region. Every week, the system CEOs had calls to connect, but every day, the system medical leads, 7 days a week for 6 months or longer, had daily phone calls. Ian and I were on the call with Jeannie Berry from our emergency department and Carla Marino from the placement department that we'll talk about. Methodist, Baptist, University, the VA, our military colleagues were on the call, Metro Health, and then STRAC Pharma, the Regional Operations Medical Center. So an amazing group of people, probably 20 to 25 people every day on 30 to 45-minute calls, 7 days a week. Next slide. Some of the topics of these calls were patient placement. As Ian talked about, there's a routine where ambulances normally go. We changed to a load balancing. Well, that went into a rotation where STRAC decided who was next up in the rotation. We took 1 in 4 patients, and we're not as large as the other systems, so we took a much larger percentage. We updated twice daily information from the hospitals about how many beds we have, what kind of staffing we had, what kind of equipment we had, so they knew exactly what we had available. We had what we call external hospitals, Lackland, the Texas Center for Infectious Diseases, and then a potential field hospital at Freeman Coliseum, but they really couldn't care for sick patients. They could only care for patients that only needed 2 liters of oxygen and no more. So we really couldn't use them for these sick patients that we were seeing. We developed help calls. The rural facilities that were trying to transfer patients in, and they couldn't find a taker. When they called multiple systems, they would call a help call. All of us would get on the telephone, often at 2 in the morning, and we would round robin until we could find a bed for these rural facilities and patients in. We developed multiple guidelines, a crisis management guidelines. CHRISTUS had its own guideline, but it was similar to the city's guideline. And these were, how do you manage when in a time of shortage? How do you decide who gets the care if necessary? We developed visitor policies, masking policies, testing policies. So we were at least similar amongst the systems. And very important is resiliency. How do we keep from burning out our healthcare staff, which is a real problem? We looked at supplies. You know, PPE was something that we only knew about in healthcare in 2019. In 2020, it became ubiquitous in the lexicon of the country. So everybody knows what PPE is, but equipment and also decontamination of those masks were centralized as well. So big work with that. We worked on staffing, we'll talk about later, but we did not have enough staffing to care for these patients. So the state and the federal government supplied multiple nurses, respiratory therapists, and doctors to help us. Mortuary management, this is not a popular topic, but the hospitals only normally have 4 to 6 places to keep patients that have died before the funeral home picks them up. If the funeral home gets backed up and can't manage the patients, there's no place to put them. So we literally had to rent refrigerator trucks and build shelves to help store patients until the funeral homes could catch back up with us. So we coordinated that through STRAC, if you will, and then outplacement. Patients that aren't sick enough to need hospital but couldn't really go home. We developed nursing homes that did nothing but COVID. We developed long-term acute care hospitals that could actually manage some patients on ventilators. And our specialty surgical hospitals also took some patients to offload so we'd have more beds available. Next slide. So patient placement, I'm gonna talk a little bit about Carla Marino's area. She's a VP of patient placement in our command center. Next slide, Catherine. The command center is a centralized transfer center for all of CHRISTUS Santa Rosa. Any patients admitted to the hospital or transferred from the hospital come through this central organization as a one number for admissions. All of our beds and the bed types, what patients are in their bed, what their problems are all in that computer system. So we'll know there's not a bed at Westover, but there is one in New Braunfels. We can shift patients back and forth. We also upload our nursing staff. So we often have beds, physical beds, but no staff for the beds. So those are unstaffed beds that are marked out as available on the computer sheet. But what a wonderful place, because we had lots of data. We knew our referral sources, who's sending us patients, what type of patients. We could manage throughput from the emergency room to the ICU, to the floor, to the skilled nursing facility. We knew those times would make us much more efficient. And then our staffing ratios. We knew what our staff to bed and staff to severity of patient ratios were. So we could track all that on multiple times a day. Next slide. A little bit about staffing. Patty Toney is our vice president of our southern district of all of CHRISTUS. CHRISTUS is about 70 hospitals in America, and Patty's over the bottom of the southern half. But Patty did a remarkable job helping us with staffing. Next slide. As we said, we had about 186 nurses supplied by the state. They had contracts with staffing agencies, and they supplied 186 RNs, 26 respiratory therapists. CATRAC is the STRAC up in San Marcos, the Austin STRAC provide 10 nurses. Our emergency group, BEA, supplied us 3 nurse practitioners out of their group. We had a separate Compass contract that supplied nurses. Then also there were some furloughed nurses that were out because they had been COVID positive, but now they weren't, that could come back and do some work. So there's an enormous amount of work that's being done. There was thousands of nurses sent from the state and the feds to all of South Texas to help us manage this, or would not have been possible without them. Next slide. This is busy, but we had a nurse staffing calculator that would tell us how many nurses we needed given the patients that we had. If you go to the bottom, starting about at the end of June, early July, we were about 17 nurses short from what we needed. Well, during the month of July, we finally got 1st of August, enough nurses to cover the patients that we had. So we went the whole month with 16, 17, 18 nurses short. So these nurses were working double and triple time, doing a remarkable job in caring for these patients. But we knew exactly what we needed and when and how. Next slide. Our highest day for Santa Rosa, this is a graph that we produced every day internally. So we knew there were 1,200 patients in the city hospitals that were positive. And Ian will show you later, we typically ran about 100 positive patients. In the month of July, it jumped up from 100 to 1,200, 12-fold increase. Santa Rosa had 177 of those patients. or about 15% of the market share. We're less than 12% of the market, so we were overrepresented in those patients. If you look at the 3 hospitals included in STRAC, Westover Hills Medical Center, New Braunfels, they typically run about 260 patients in beds. We had 177 that were COVID positive, or as many as 70% of our patients were COVID positive in those hospitals, which meant a lot of people who needed care were not in the hospitals getting care, which is the real challenge. We had 66 patients in our ICUs and 48 patients on ventilators, which meant we had to open up brand new floors, make them intensive cares, break out windows, as Dr. Thompson showed, to put in filters to filter the air. So we created brand new ICUs out of multiple new floors, which is really remarkable. Next slide. So I'm going to turn it back over to Ian now for our what we did at the medical center.
Thanks, Dr. Davis. So again, going back to the original concept, Santa Rosa and San Antonio, as I was saying earlier, we saw some of the very first COVID patients in all of the United States. And the very first one that was seen by CHRISTUS was one of the cruise ship passengers that arrived back in the early part of February. And this patient took a tumble, and there was not a whole lot known about this virus at that particular point in time. And so what you're seeing right now is several of our radiologists and infection preventionists who are outside and actually shot the X-ray while the patient was sitting in the ambulance. Next slide, Catherine, please. And then more of the evacuees arrived. It became apparent that a relatively small number of these Lackland quarantined individuals were developing COVID. Additionally, in the absence of STRAC assistance, at that particular point in time, we didn't have enough nurses to be able to stand up Bandera. And ultimately, it was not put to use. Although at a point in time, the STRAC leadership walked through and said, this is absolutely perfect for the response to a pandemic. So it shows that we're able to respond extremely quickly. And ultimately what happened was that our hospitals designated units and medical center designated 2 units, a COVID ward as well as a COVID ICU, because we knew that these patients were getting sick and would be on ventilators and would have to go to the ICU. And part of the responsibility is protecting our associates, our nurses and respiratory therapists and physicians, as well as at this particular point in time, not knowing if we had enough personal protective equipment, stewarding that PPE appropriately. Next slide, please, Catherine. And so then this all that we all remember begins. Citizens respond. Remember, we kind of shut down originally. And next slide, please. I draw your attention to Dr. David Hinkas's daughter did this graphic that ended up on the front cover of the San Antonio medical organization's front page, and as well as we posted this in the front of Medical Center Hospital to emphasize the importance of protecting our own health. And Santa Rosa went, the zenith of this experience was when CHRISTUS Santa Rosa and all of our hospitals did all of this to protect our associates, patients, families, physicians, and so forth. Next slide, please. And so here were the inbound patients that were coming, where they were coming from and where they were going to. And you can see Medical Center got the bulk of these. Santa Rosa Hospital and the Children's Hospital of San Antonio, as well as Westover Hills. Substantial increase in the number of calls into our command center during this period of time. Next slide. These COVID patients came not just from emergency centers across San Antonio, but all across Texas. And the initial goal was to put all the patients at Medical Center Hospital. And these outside facilities, Valverde, Del Rio, down to Laredo, down to our spawn facilities and so forth, who were accustomed to sending the sickest of the sick, put their patients on helicopters, put them in ambulances, and sent them to Santa Rosa. And you can see this is one of the first COVID patients arriving at Medical Center Hospital via air ambulance. Next slide. Initially, 2 units were designated as COVID, a medical surgical for non-critically ill patients, as well as a COVID ICU. And the medical ICU was converted to COVID, and these units were sealed such that only certain individuals were allowed to have access. And you've seen this across all the issues that were described across the United States. Santa Rosa and our healthcare ministry were at the very forefront of this for San Antonio. Next slide. Initially, they were placed in negative pressure rooms, but unfortunately, I'm not sure most people understand it, but in a 20 or 30 bed unit, generally no more than 1 or 2 of those rooms are negative pressure. And so what we ended up having to do was at the end of this hallway down here, putting a filtration unit, and at the end of the other hallway in the other direction, a filtration unit, turning the entire unit into negative pressure. And this then allowed the nursing staff to wear personal protective equipment in there and effectively seal the unit from the rest of the hospital so normal operations could continue. Next slide, please. In the ICU, we began to witness the tragedy that is COVID. These are very sick patients. And as you can see, we have nurses and other staff in here wearing their PAPRs. These are pressurized units that pressurize air into that so that there is no airflow from outside. These have filters on them. Very, very sick patients with the healthcare professionals that are taken care of. The ICU nurses 24 hours a day, respiratory therapists who are tweaking the ventilators to maintain the very best oxygen exchange for the patients, pharmacists who are bringing the new medications to bear to this, intensive care physicians who are pulmonologists with specialty expertise in critical care medicine, as well as laboratory experts who have the expertise in testing for COVID. And we were very fortunate to have an infectious disease expert who during this period of time seemed to live in the hospital. We've been absolutely blessed by extraordinary expertise, extraordinary associates who made this care possible. Next slide, please, Catherine. Initially, what we did was we had the medications for these patients outside the rooms. We subsequently learned that they were best off inside the rooms. Next slide. And the initial experience in San Antonio began. And so what you see right here was from the February to the June timeframe, it was about 100 patients in the San Antonio hospitals. So it was steady state for a long time. A lot of that was due to that initial San Antonio response by Mayor Nirenberg and Judge Wolf to close the city down, stabilized it so that San Antonio hospitals could rev up their capabilities. Next slide. Then what happened was Memorial Day. And these are pictures from the Herald Zeitung, which is the New Braunfels newspaper, and you can see what happened. And quite frankly, amongst the medical professionals in San Antonio, the epidemiologists and the public health professionals, this behavior broke our hearts because, next slide, that's what we saw afterwards. So we saw the spike as the disease exploded in San Antonio. And these are only the PCR positive patients that are counted in the hospitals, where you saw Dr. Davis's, that 1267 was the spike that we saw in July, the mid portion of July. Next slide. That happened, medical center. We first cohorted the patients. We developed that freestanding ICU. We began that clinical trial of convalescent plasma. By mid-July, we had treated over 400 patients on a Mayo Clinic sponsored clinical trial using convalescent plasma. In fact, I wrote a letter to the governor of New York thanking him because a lot of that plasma came from New York, who had this experience before we did. We put patients in the prone position. We anticoagulated them, treated them with steroids. We were some of the first hospitals to use remdesivir, that you're aware of from Gilead Pharmaceuticals. Extensive patient and healthcare worker infection prevention practices were put into place, and these dramatic hospital renovations to significantly expand our capabilities. Next slide. And if you look at to see what happened, a normal July versus the Corona July, we would have normally been doing about 90 cases a week. It dropped because a lot of the quote unquote elective cases, which included cancer cases, dropped off. Our census went from 70 to 130. Medical center before the STRAC nurses, like Dr. Davis pointed out, was staffed for at the most about 80. So we had this huge increase in the number of patients. The staffed ICU beds, staffed for no more than 18. We opened 4 ICUs, going up to 53 ICU patients. And at the peak, we had 52 occupied beds. And the coronavirus census went up from none to 70. Ventilators went on average from about 2 at any one point in time to 30. And the CHRISTUS Santa Rosa response to this was absolutely magnificent. We never ran out of PPE. We never ran out of ventilators. There were ventilators that were moving back and forth. They were going into depots around the United States to make sure we always had everything that we needed. Next slide. Here's a board. You can see it's blanked out for patient names. This is Annabelle, who is one of our house supervisors, our lead supervisor, moving patients around to make sure that they are in the right location, because we'd have a patient on the ward that would be on a high flow oxygen and that would decompensate and need to go to the ICU. Next slide. We had pre-screening outside our emergency departments, staffing these locations. Next slide. We also had staff locations at the entrances where our associates and physicians and anybody who is coming into the hospital were screened for symptoms and temperature checked. Obviously, PPE was required, masking was required throughout the hospital. Next slide. Now screening is very different. We'll go to the next slide. We now have an automated system that's done on your phone, and then it brings up that QR code. You can see a picture of me. There's a little iPad that's mounted on the wall, and you rapidly can make sure you have no symptoms, and then we're randomly checking temperatures in individuals. So it became automated, and it's automated to this day. Next slide. We accelerated our COVID testing capabilities. So these are antibody tests. As you can see on the left, the C is a control. IgG and IgM are the COVID response. And on the right-hand side, you can see the one that's positive with both IgG and IgM. The M is the rapid antibody that comes, and the G is the long-term antibody, enable us to segregate patients very quickly. This can be done in about 12 minutes or so. Next slide. And the next slide you see, this is Brenda Davila, who is the laboratory director at Medical Center. And the machine just to her right on your left is an 8-channel PCR machine that can run 8 tests concurrently every 45 minutes. And the slide that you see on the right, you can see there are some tests that are waiting to be put into the machine, so we can rapidly determine, is this patient a COVID patient or not? Put the patient in the right location and segregate patients to keep everyone as safe as possible. Next slide. And here you see Dr. David Hinkus, who's the laboratory director, who is curating all these responses and making sure that they're getting back to the nurses and back to the physicians to provide the very quickest response, the most accurate response. Next slide. This is an example of what we saw. This is a normal chest x-ray, and you can see what happens very quickly as the COVID virus causes the lung to be compromised dramatically. And these patients can really dramatically change very, very quickly. And our associates and our physicians were able to respond very quickly and provide the medications. Next slide. And here are the medications. So remdesivir has a small amount of benefit. It reduces the symptoms from 15 to 11 days. Just recently, last week, I saw that Gilead Pharmaceuticals had made about $890 million in sales of this. It has helped some. Convalescent plasma, actually, we still don't know the exact impact, but we saw some remarkable responses. Steroids at the bottom left, you can see the dexamethasone. It reduces inflammation, prevents that pulmonary change that you saw in the x-ray. And statistically, one life is saved for every 8 patients that are on a ventilator. And the bottom right that you see here, the Regeneron experimental monoclonal antibody that's just beginning to roll out, that President Trump received when he was at Walter Reed. These are the big 3 on the left, as you see here, as well as good medical care, quality infection prevention, and each one adds to the ability to control this disease. Next slide, please. Just FYI, the hydroxychloroquine that was touted at the beginning based on results from Belgium and France, it appears based on everything that we know, this is a recent paper in the New England Journal of Medicine, which, as you probably know, is the premier medical journal, really does not show any change in the complications or the death rate. In fact, there was a little bit of an excess death rate with the patients who've received hydroxychloroquine. So Medical Center and CHRISTUS Santa Rosa were on the really the cutting edge of providing the very best of care to the patients. Next slide. I took this picture from the OR board upstairs. This has been a very challenging time for our nurses and respiratory therapists and others that are working with them. They worked very, very long hours. Then they had to go home, had to go shopping and so forth. And when they went to the store, they found that the shelves were empty. And what were they to do? Next slide. We saw a remarkable response. HEB pulled on a regular basis, came and provided the meal simple, which my colleagues at HEB say are anything but simple to prepare, provided these to our associates who were able to have them at work and take them home and help them. You can see a very grateful group of folks that were out there, our directors. Next slide, please. As well as our colleagues with Aramark helped stock a little mini grocery store in the hospital, so that for anything that you might need, you know, kind of the basics, you'd be able to take care of it, as well as fresh fruits and vegetables. Next slide. You see, by the way, importantly, you can see that this slide occurred before we did universal masking. Remember those days where it was originally thought you didn't have to do that? That's why the folks are not wearing masks at this point in time. That subsequently changed. Next slide, please. There were unanticipated consequences, and this is important for all of us to remember. Patients stopped going to their physicians. ER visits dropped precipitously. We had to close our Elan emergency department because it was not feasible to keep it open. We didn't have nurses, and actually there was a dramatic fall in the folks that were going to emergency departments. And unfortunately, this will have long-term consequences in patients, adverse impact on physician practices, hospitals lost billions of dollars, and worst of all, the normal kinds of prevention practices like mammography and colonoscopy dropped dramatically, and there have been estimates that there will be lives lost as a result of that, unfortunately. That's why it's so nice to see some of the changes that we're witnessing as of today. Next slide, please. And so we can go on. That's the taking those down. And the worst part, I like to say, was couldn't go to my barber. We began to change a little bit. Next slide, please. And this is perhaps the best slide of all. It's the code home, and Dr. Davis put this in. I think this is over at Westover for one of the patients that's going home. And it's completely fitting and appropriate that we're having the discussion today, because it was announced a few hours ago that the results of the Pfizer trial of the vaccine were extremely promising. The initial news reports are showing that it's not 60 or 70% effective, as a lot of them are, but it appears to be more like 90%. So our prayers should continue that this will be possible for us. But we are looking forward to some promising advances, and I suspect that none of us will ever take things for granted again. Grandchildren or children on your lap, going to birthday parties and anniversaries, going to the movies, going to concerts, sitting next to someone in a restaurant without a mask on. But we will get through this, and the Christus Santa Rosa community has done just an extraordinary job. We have time for some questions, and if you will use your chat function, we'd love to hear your questions with regards to how Santa Rosa responded. Dr. Davis and I are here to help be able to respond to that for you. And for those of you who cannot stay on, we would like to thank you for joining us for this. The story's not over. The effort is continuing. We're seeing an increase in the number of cases and the number of hospitalized patients in San Antonio. The number of patients in the ICUs are going up. Please pass along to everyone that you know and everyone that you love to please do your social distancing, wearing your mask. We will get through this. The vaccine will be here. They're talking about potentially delivering the first doses of the vaccine by the end of the year, and Pfizer is anticipating 1 billion doses or more during the course of 2021. So a question was asked about what's the benefit of flu shots. Dr. Davis, would you address that, please, sir?
I'd be glad to. You know, the Southern Hemisphere has the opposite winters and flu seasons than we do. And there was some good data that showed people that got flu shots had a lower incidence of getting COVID, and they did better when they did. Now, there's no direct protection from flu shots, but they thought maybe it revved the immune system up enough, but the immune system was overactivated. Plus, now we're in the flu season. You don't want to get the influenza. People die from influenza as well, and you can get both. Hopefully nobody does, but you can get both. So getting a flu shot now is very, very important, especially for those of us at risk that are older with any chronic disease. So don't put it off.
Yes. And just to let everyone know that all of our Christus Santa Rosa associates, the deadline for them to receive their flu shots was the last day of October. So we are extremely focused on the health and well-being of our associates because they are the ones that are providing this extraordinary care. There was another question. Most businesses have learned that from COVID that things are changing and adjusting their business models. Are there things you learned that will change your business model? So the short story with regards to the business of medicine is that it's changed dramatically. And I think my suspicion is that most everyone has had this experience that you went to see your physician via Zoom or FaceTime. And what's happened is that a lot of folks have begun to realize that telemedicine is an extremely powerful way to practice medicine. So we've done that. We did that in the hospital as well and in the emergency department. We enabled physicians to rapidly respond to situations in the hospital or in the ER via telemedicine. But this is not something new. For example, teleneurology and telepsychiatry has already been in place. And for that Bandera location from a critical care standpoint, a critical care response cart was put into place so that a critical care specialist can interact with the patient immediately. And for example, in the case of stroke, a patient comes in with a stroke where time is of the essence. A teleneurology consult is the quickest and most effective way to respond to this. So Dr. Davis, would you take Mary Kay's question about how should we respond to folks who say COVID is just a bad flu? It's just the flu. You're muted, Dr. Davis.
The death rate from COVID is at least 10, if not more times more deadly than influenza. Influenza, often older people have some immunity because they've been exposed to many, many previous influenzas. But with COVID, older people are at risk. There are lots of reasons that young people don't get it. With flu, it's pregnant women and young people that are very likely to die. with COVID, it's the older folks. So it's much, much more deadly, much more transmissible probably as well. This is the perfect weapon as far as being easily transmissible. We went from 7,000 cases, Dr. Thompson, 10 months ago to millions and almost billions of cases now over a year. So enormously transmissible. People don't have symptoms when they're first infected, and they're very infectious in the first 4 days, and they don't know they have it. So it's very deadly because people are out there not masking. You think that my grandchild who's 15, I want to hug them because they have no symptoms, but they may be asymptomatic and shedding virus. So very transmissible, very deadly. The treatment is really awful. I mean, you talked about proning people, which means people are on their stomachs. They have high flow CPAP. They have a mask on with very high pressure, and that lasts about 3 weeks for most people. And people are not coming in the rooms because they don't want to get sick. When they come in, they're totally wrapped. So there's no human contact. So it is an awful, awful, awful thing to get. With flu, we have, Tamiflu and other things that if started early can help with the course. Right now, there's nothing that we know of that recognizes early COVID and has early treatment with the same kind of efficacy.
That's a very good point, Dr. Davis, and I'll just go out on a limb. When I hear from individuals or on social media that this is a hoax, it breaks my heart. All that you'd have to do is to witness a family member or to walk through one of the COVID units and seeing so many folks who are intubated, so they have a breathing tube down, that are there for sometimes weeks, months, and then what ends up happening is that you get the other complications like kidney failure and other problems, so that even if you do survive one of the bad cases of COVID, it changes your life forever. And so prevention is absolutely essential until we have our vaccine. Jim Scheel asked a question. We're coming into the holiday season when families and friends like to gather in large numbers. In addition, many people are ready to go out and celebrate. How would you respond to these folks? There's only one response, and that is if you love your friends and if you love your neighbors, which is what our Lord and Savior told us to do, we need to love them from a distance. It's just not the same. But if we can just hang on for a little bit more, I mean, the scientific apparatus of the United States has been, I have witnessed this. I sit on a board for the National Cancer Institute, which has worked very closely with the National Institute for Allergy and Infectious Diseases. The amount of effort that has been put into this, this Operation Warp Speed, such that it's never been done like this before, that you develop the vaccine and at the same time you go into full force production. We are going to get through this, and it's my full anticipation that by summer, fall, or this time next year, we'll be sitting next to each other in movie theaters. We'll get through this. And the trick is, as Dr. Davis said, is to hang in there, protect ourselves, especially the folks that you love, and maybe, cook a turkey and put it in a little bit of a to-go box and drop it off at the folks. It's just not the same, but we really need to protect folks, especially as Dr. Davis was saying, because of this asymptomatic transmission. Well, Dr. Davis, do you have any closing comments for us about this extraordinary Christus Santa Rosa response to the COVID pandemic?
It's really been incredible. And prayers, we're strong believers in prayers and God's grace. So please keep the prayers going. But the Lord told us to be safe and protect each other. And then I get to St. Francis's prayer again to close, that in forgiving and giving is, I think, what we need to be doing as a society. So I can help someone else by masking. Masking doesn't help me, but it helps someone else. So I'm helping others by masking and being safe.
Wonderful. Thank you, sir. Thank you, Dr. Davis. Thank you, Catherine, and everyone who helped put this, Laura, for helping put this together. Most of all, thank you all for joining us, and may God bless you and keep you safe. And we will look forward to one of these days having a noon get together where we can all sit down together. That shouldn't be too long in advance. And please, as Dr. Davis said, please keep all of our associates in your prayers, as well as our patients and their families. God bless. Have a beautiful day.